Good afternoon, everybody, and thank you very much to the Breast Cancer Foundation for inviting me to speak today. And hopefully we are doing a bit of a change in moving towards the survivorship phase of breast cancer and the topic of lymphedema, which I know is often a topic of hot interest for women diagnosed with breast cancer. This is where I work at Macquarie University, and we're known as the ALERT program, the Australian Lymphoedema Education, Research and Treatment Centre. We run programs where we teach health professionals to become lymphedema trained therapists. We are involved in various research projects, including some international randomised controlled trials in lymphedema, and also we have a conservative and surgical clinic. And we actually taught a team from New Zealand, from Auckland, a few years ago in doing liposuction surgery for a very advanced lymphedema, which some of you may have heard about. This is part of our team. And so today I'm talking about lymphedema, and I call lymphedema to be a survivorship issue of breast cancer. It's often the daily reminder of a woman having had breast cancer. We know that often the treatment for lymphedema is wearing a compression sleeve, but you can't hide a compression sleeve. So you could be sitting in this room and no one need know that you've had a diagnosis of breast cancer. But as soon as you are seen wearing a compression sleeve, that causes interest in people, and people want to know, why are you wearing that? What's that for? And then you as an individual have to decide, do I want to tell that person that I've been diagnosed with breast cancer and this is a result of breast cancer? And so it affects individuals not only physically, but also psychologically, functionally, and also there's an economic, financial impact of having this condition. So lymphedema is the accumulation of excessive amounts of fluid resulting in swelling in one or more regions of the body. And after breast cancer, it's usually the breast or the arm, and sometimes both. And it can often occur from merely having surgery to remove lymph nodes, or also some of the treatments in radiotherapy and perhaps some of the taxane chemotherapy drugs. So risk factors. I think I've learnt over the last 20 years that we can't now educate every woman who's had breast cancer about lymphedema in the same way. I think we have to do what we call risk stratifying, because a woman who's had one sentinel node removed surgically is at a very different risk to someone who's had 30 or 40 lymph nodes removed in a complete axillary dissection. But these are the known risk factors, the extent of surgery, and depending on the number of lymph nodes removed, whether a woman has radiotherapy to the axilla region. And then we also know if a woman has trauma to the affected limb or the limb at risk, an infection, or we call that cellulitis often, and people are often at risk of increased chances of cellulitis after they've had their lymph nodes removed. Body mass index, if someone has an elevated BMI at the time of their breast cancer diagnosis, then their research has shown they're in a higher risk of developing lymphedema. And that links then to if they're immobile, so large and immobile, they're not moving. We know exercise is the key thing to help here. And there's some mixed research out there at the moment about the effects of the taxane chemotherapies in whether it increases risks of lymphedema. And there's some papers for and some papers against. We know that early signs of lymphedema aren't just you wake up one morning and you have a swollen arm. Usually the symptoms are vague and may include feelings of heaviness and aching in the arm, some tightness or fullness, or you might notice that rings or jewellery feel a little bit tight or sleeves feel a little bit tight. And often in the early stages, the swelling's transient. So you might wake up in the morning and the arms are the same size, and by the end of a busy day, you might notice some puffiness in your arm. What we do know, however, is that early detection and effective management can really reduce the symptom severity and improve quality of life. And there's a lot of research now that's really supporting a model of care of early detection and what we're calling prospective surveillance. So 10 years ago or so, I was working in a large teaching hospital in Sydney, and our waiting lists were overwhelming because of people being clinically diagnosed with lymphedema. So they noticed swelling in their arm, they went to their doctor and they were referred to our clinic for lymphedema treatment. So at that point they had what we call clinical lymphedema, and once you've got clinical lymphedema, you're left with managing that condition as a chronic condition as a side to the breast cancer treatment and everything else you've gone on with. So back in 2012, the Australasian Lymphology Association, which is the peak body for Australia and New Zealand, developed this position statement that said that all women should be monitored for the early detection of lymphedema following breast cancer. And it also endorsed the use of bioimpedance spectroscopy, or some of you may have heard of the word L-Dex, as a validated and reliable tool to enable the early detection of what we call subclinical lymphedema. And I'm going to share what that means. So in years gone by, we knew internationally that there were 3 diagnosed states of lymphedema, or stages of lymphedema. We had stage 1, which we called mild lymphedema, stage 2, which was moderate, and stage 3, which was severe. And as I said, once you developed any of these stages, you were living with lymphedema for the rest of your life, and we were treating it, we were reducing the symptoms, reducing the severity, but you were left with it. And as I said earlier, the key treatment is often wearing a compression sleeve, like a compression surgical stocking. But in some recent literature, we now know that there is stage 0, and this has been adopted by the International Lymphedema Society, and we call it subclinical or latent lymphedema. Now, this is lymphedema where you can't actually detect it with a tape measure. So normally we would use a tape measure to compare the affected limb with the unaffected limb to work out what the difference in the volume is. But in stage 0 lymphedema, it's not usually visible to the naked eye, so we can't see it. And what we believe is that women can sometimes be in this stage 0 lymphedema for a significant period of time, perhaps months or years, before they might progress to the clinical lymphedema that we saw earlier. And so there's a lot of work now looking at how can we manage this subclinical lymphedema and see if we can prevent it from progressing to clinical lymphedema. And some of this work has been led by this technology called bioimpedance spectroscopy, or L-Dex. So L-Dex is a non-invasive method of determining extracellular fluid, so comparing extracellular fluid in the limb at risk compared to the unaffected limb. And some of you may be familiar with having these L-Dex measurements. This is called the U400 device. You lie down, you have little electrodes put on your hand and one on your foot. A very small electric current moves between the 2 arms. If someone has an increased extracellular fluid, then the signal moves through between the cells quicker and it gives us a higher reading, what we call an L-Dex reading. So the normal range for the L-Dex reading is between -10 and +10. And what we now know is that if you get a change of up to 6.5 points from your baseline reading or outside of the normal range, then this is what we call subclinical lymphedema. So it's not measured by the tape measure. If you did the tape measure, it would be the same, but it's measuring extracellular fluid. And more recent research has shown that if you get a change of 7 L-Dex points from your baseline or outside of the normal range, then you've probably gone into that clinical lymphedema. So this has interested me for some time. I work in a private practice now and have for about 16 years. And this research is Australian research. The technology is Australian. And this is just a patient that was followed up in some of the very early research of this bioimpedance spectroscopy. So this woman has been monitored for lymphedema using a tape measure and the L-Dex technology over a 2-year period. This study wouldn't be approved by an ethics committee now because of the work that's happened since the early 2000s. But if we look at this case, and I'm just going to go through fairly quickly, we've said the normal range is 10, and at that point there, the woman went outside of the normal range. We kept monitoring, and the woman identified some symptoms that something's not right. The jewellery was a bit tight, things weren't right in her arm. And at this point here, where the L-Dex was 13, the tape measure showed a difference. So she did actually develop clinical lymphedema up at this point. But the difference between the L-Dex outside of the normal range and when the tape measure showed was actually an 8-month period. And in the whole study that was published, the average time from going from L-Dex change out of the normal range to clinical lymphedema was between 6 and 10 months. Now, as a lymphedema therapist, that's a long time that we could actually be intervening and trying to help support a woman to prevent from getting into clinical lymphedema. Now, part of this study was to monitor women before they had their breast cancer surgery, so before their lymph nodes were removed. And that's what happened in this case. So this lady's pre-surgery baseline was minus 4.4. And I've already said that when we get a change of 6.5, that's when we need to intervene. And if you look at this patient, look where that change is around at this point here. We should be intervening with a simple compression sleeve for 4 weeks initially to see if we can stop that progression going to clinical lymphedema. We're part of a big international study in Sydney at the moment that's recruiting worldwide 1,100 patients, and we're just over 1,000 at the moment. So we're getting close to recruiting all the women, and we're monitoring them for 3 years from their baseline, from time of diagnosis, and we're following the protocol of providing them with a compression sleeve when they get this 6.5 change in the L-Dex reading. There's lots of ways that we can manage lymphedema, and obviously the earlier we get it, the less intensive intervention we need. So some of you may have had contact with a lymphedema therapist, and I call it my toolbox, my toolkit of a whole lot of strategies to manage lymphedema. And as a private therapist, and with the introduction of L-Dex, I was thinking, something's changing here. My practice is changing. And that's where I have done some collaborative work with colleagues actually here in Auckland, and I can see Robert up the back. I always get nervous when Robert's in the room. But Robert and his colleague Philip from AUT here have been the statistical analysis people on our team to look at this data that I'm going to present to you, and I thank Robert for his expertise. So what we've done is, for a long period of time in my private practice, I had patients coming in what we would call the traditional referral-based model of care. So they were referred from oncologists or surgeons to manage the problem that the woman had. So they come to me with onsets of symptoms post-breast cancer treatment, not necessarily lymphedema, just problems with their arm. Referred to the lymphedema therapist, they were assessed, diagnosed and treated. And I don't just do lymphedema, I look at the whole person in range of movement, scar management, psychosocial support, and then we would give them regular follow-up visits for monitoring and intervention. The second group was this new group since I had the L-Dex technology, and this is what we're calling the prospective surveillance model of care. And this is where I try to see women when they're first diagnosed of breast cancer, so right back in the beginning, or within 3 months of their diagnosis. And at that time, I give them education, I take baseline L-Dex measurements, and then I monitor them at regular intervals throughout their breast cancer treatment and beyond. And the aim of our study was to determine whether this new model of care, what we're calling the prospective surveillance model of care, using L-Dex, results in earlier detection and effective management of breast cancer-related lymphedema. So I look back at 10 years of my clinical data, and there was 473 women that I'm going to report on today. We had 188 in this prospective surveillance group, so who had come to me at time of diagnosis or within 3 months. And then we had the referral group who were referred from St Elsewhere's at least 3 months post-diagnosis. The average time was 2 years. The big key message out of this data review, and we've got lots of data to analyse, but I've only selected a few key points for today, is that out of the surveillance group, 75% of the women did not develop lymphedema in the time that we were reviewed. And out of the referral group, 60% did not develop lymphedema. When I divided it up into the stages of lymphedema, and I as the clinician defined what the stage of lymphedema was on my assessment when they got a change in their L-Dex readings above the norm, 10.3 were stage 0, so the subclinical, 10.3 stage 1, and only 4.3 stage 2, and none went on to stage 3. As opposed to the referral group, where 23% of them, this group, were barely anyone was stage 0. They were already into a clinical lymphedema stage. Okay, Now I'm going to just show you this one before I finish. So what it actually showed us was that the women who came in the prospective surveillance model of care had lower L-Dex readings at baseline, and then as we followed them on for 5 years, they were always lower than the referral group. And even though women who may have gone on and developed lymphedema, if they were in the surveillance group, their lymphedema was less severe and required less intensive treatment, which is a real bonus for those women. So I guess in conclusion, international guidelines, both in Australia, New Zealand, in the States and in the UK, are really urging that lymphedema surveillance and early intervention be implemented routinely after breast cancer treatment. And results support the use of L-Dex as part of a prospective surveillance model of care that may result in early detection and early diagnosis of lymphedema, as well as lower L-Dex readings over time. And hopefully, if further research proves this, remember this is my clinical data, but supporting other research that's out there internationally, that hopefully early detection of lymphedema will lead to lower health costs if it results in effective management of lower symptoms and prevents progression to severe disease. And I guess just for those of you who may not have had contact with a lymphedema therapist, this is the ALA, so the Australian and New Zealand Lymphedema has a register of lymphedema practitioners, and you go onto the website and you can put in your postcode in New Zealand where you live, and hopefully a qualified lymphedema therapist will be within reach for you to be able to see, knowing that the lymphedema therapist can assess your arm function, can help with range of movement, mobility, scar work, and also in the management of early signs of lymphedema. Thank you for your attention.